Um, I think we're going to get started here. It's great to see so many so many heads here on Zoom. Um, and we're really delighted to have Eric Jutkowitz as our speaker today. The number of us here at Heads have worked with him or will be working with him. He's just been a terrific partner for us, and his work is so connected to the work we do at Heads. Just the blurb here, I'll read a little from his bio. Eric's research is focused on understanding the value and quality of care delivered to vulnerable populations, with an emphasis on the role of informal long-term care system. He's done a lot with thinking about cost effectiveness of non-drug interventions aimed at older adults and caregivers, and really with a focus more recently on dementia, thinking about Medicare expenditures in that area, and has developed a microsimulation model that predicts dementia progression and associated costs. He's visiting us virtually from Brown University, where he's an associate professor of health services policy and practice. And the title of his talk today is on the slide. So with that, Eric, welcome for your talk today. We're excited to have you. I'll turn it over to you.
Thanks, Dan. Nice to see a lot of familiar faces. I heard you're an informal group, so feel free to jump in with questions at any time point, either in the chat or if you want to speak up. I can't really see the chat, so Dan, if you just want to call out that there's something there, that's cool with me. As Dan mentioned, I'm going to be talking about some of our work we've been doing looking at the cost effectiveness of non-drug dementia care interventions. So I'm going to spend just a little bit on motivating the topic. We'll talk about, share some data on the prevalence of dementia. What's really interesting for our group as we think about non-drug interventions are the types of care settings that are able to support the implementation of these types of programs based on their funding model or organization of care. And so we'll share some data we've looked at in terms of the prevalence of dementia in Medicare, Medicare Advantage, in the VA as some different examples. And really, in terms of the context, again, ultimately in what systems would or would not be able to support some of the interventions we'll be evaluating in terms of their cost effectiveness. We'll also share some data we have on different types of caregiving arrangements and looking at the diversity or variation in caregiving arrangements, which I think also is important in trying to think about and understand who are the sort of types of people that would be able to receive many of the non-drug interventions we're evaluating versus those that may not have historically been included in intervention studies, and really trying to pinpoint like what is our target population. And then with that background in place, we'll talk about the work we've been doing modeling the cost effectiveness of non-drug interventions. We developed a person-level microsimulation model that simulates an individual from the time they're predicted to have diagnosis until they die. And we model their declines in their clinical features of dementia, their cognition, their function, their behavior, how those clinical features are associated with different types of transitions, going from the community to a nursing home or transitioning to be Medicare, Medicaid beneficiaries. And so we'll talk through the structure of the model, really go into detail about how we're parameterizing the model, the data we're using to inform the model parameters, and then we'll talk about our actual work modeling the cost effectiveness of various non-drug interventions. So, a lot of you probably know this, but dementia is a complex neurodegenerative disease. It really involves a number of symptoms. The sort of three key hallmarks are probably the cognitive declines, the physical function declines, and up to, I think 97% of people with dementia will exhibit some sort of challenging behavioral symptom or symptoms, things like agitation, aggression, wandering. Every time I look in the literature, the prevalence estimates for the number of people in the US with dementia seems to be changing slightly. I think last I looked, the estimate was between 5 to 7 million Americans, people in the US are living with dementia. And there's really a substantial number of unpaid caregiving involved from family, friends, other relatives who really do the majority of the work. And what I want to do next is I'll share some data just showing that there's a lot of diversity in terms of the settings in which people with dementia receive care, their sort of insurance coverage, as well as meaningful variation in caregiving arrangements. This is some data we've published, and then data other people have published as well, on the prevalence of dementia in Medicare fee-for-service, Medicare Advantage, and the VA. I think as expected, right, the prevalence of dementia increases with age. What's really interesting to me is that, when we're looking at the Medicare fee-for-service versus Medicare Advantage comparisons, Medicare fee-for-service seems to be taking care of more people with dementia, even though Medicare Advantage is probably more aligned and better set up to actually implement and fund some of the non-drug interventions that I'll be talking about in a bit. It wasn't until really recently, I'd say within the last maybe 2-3 years, that Medicare fee-for-service has started to implement some payment codes that now might make it possible to get reimbursed for some of the non-drug interventions we're talking about. But historically, it's been really challenging to get these interventions funded, yet Medicare fee-for-service is providing the majority of coverage for people with dementia. I also do work in the VA, and so we did a study looking at the diagnosed prevalence of dementia in the VA. You can see it's super low. And again, we're looking at diagnosed prevalence. And so this reflects sort of, I think, historical VA culture in which they really weren't seeking out and screening people for dementia. And there's been sort of known underreporting of dementia in the VA. But what was striking to us is we had done some studies looking at premature biologic aging in housing insecure veterans. There's this hypothesis that people who experience homelessness have accelerated biologic aging. And one way we were starting to think about whether or not we could test this was to see whether or not these veterans had higher prevalence of geriatric syndromes earlier in life. And so we looked at a number of geriatric syndromes, one of them being dementia. And you can see that the prevalence of dementia among housing insecure homeless veterans is rather large, especially in comparison of the VA population. And so as we start thinking about these different populations of people with dementia, your veteran who has experienced homelessness or at risk of experiencing homelessness is going to have a very different sort of family structure, ability to receive caregiving support than probably your average Medicare fee-for-service beneficiary or your average Medicare Advantage beneficiary. And again, this has implications as when we start thinking about the non-drug interventions we're going to be evaluating. The other thing that I found striking here is that, like Medicare Advantage, VA is probably the best system in the country that could implement many of the non-drug interventions that we'll be looking at in a bit. So we've also done some work looking at the amount of caregiving people have received and who's providing care. A lot of the non-drug dementia care intervention research typically enrolls a primary or single caregiver and hasn't really included sort of the caregiving network or all the individuals that provide care. And so we were interested in looking at like how many people are providing care. Who are these people in relation to the person with dementia? So this is data from the Health and Retirement Study. What we did is we identified people in the first wave, they were predicted to have dementia, and then we followed them up to 8 years after their predicted incidence. And we followed them while they remained in the community or and alive. And so if somebody transitioned to a nursing home or if they died, they sort of fell out of our cohort. And so you can see over time, the number in the panel decreases. As expected, the amount of caregiving received in terms of monthly hours of care increases with time. But what's important from our perspective is really the variation in the number of people that are contributing to caregiving hours. So clearly spouses are contributing, but also adult children, other relatives, and paid caregivers. And so as we start thinking about various non-drug interventions that target or seek to enroll a primary caregiver, we have to think about who that primary caregiver is in relation to the person with dementia and ways that we can support the full caregiving network. Factors associated with receiving more care, maybe not surprising, but having more functional limitations was associated with receiving substantially more family, friend caregiving, as well as the wealth of the person with dementia. So the previous slide was about over time, longitudinally, the amount of care provided by family, friends to people with dementia. We were interested in sort of disentangling at a point in time the variation in caregiving networks. And so what we did was we took a cross section of our cohort of people with dementia. We stratified the sample into people who were married and unmarried, and then we did late-in-class modeling to understand whether or not there were different structures of caregiving networks. And so on the left side of the figure, these are people who are married, people with dementia who are married. On the right side were unmarried people with dementia. Typically, their spouse had passed away. What we can see in both of these is most people with dementia belong to sort of this shared care class. So they're receiving care from a number of individuals. There's not really a dominant person providing that care. And while the shared care class, the amount of care they're sort of receiving is low relative to the other groups in the figure, overall, this is a fairly high amount if you were to compare it to sort of an average older adult without dementia. In the married sample, about 20%, 18% of people received the majority of their care from spouses, and then a very small number, 4%, received the majority of their care from adult children. Looking on the right side, in the unmarried sample, 12% received most of their care from children, so children were sort of the dominant caregivers, and then this sort of one-off group to the right, 5%, they're receiving a majority of their care from paid individuals. And if you were to have looked at the demographic characteristics, you may have been able to guess that the people on the far right, the paid dominant care class, actually had the highest net worth out of all these groups. So a number of people have looked at the cost of dementia.
Can I ask a question about that?
Sure, yeah, Dan.
I love that slide. But I'm just thinking like supply versus demand. You know, like the hours of caregiving must be related to not needing a lot of caregiving. But if you like held that constant, the amount of care needed, you know, how would those, you know, that change? You know what I mean? It's a nice descriptive of this equilibrium, but you know, sometimes the person needs care and they're in a particular class or situation and they're not getting it, and other times they are. You're just able to observe what they get when they need it. It's kind of an equilibrium.
Right. Yeah. I mean, it's hard to, with our data, just cross-sectional disentangle, I think, what you're trying to get at. The groups that are receiving more care on average, they have more functional limitations. And so, you know, one guess would be if we're looking at like the unmarried group, like that class 2, that probably represents more of a moderate stage to advanced stage of dementia, where like a child is kind of stepping in and providing a majority of that care. But it's challenging to fully sort of disentangle the picture you're talking about with you know, the data.
I think one of the things I look at is that class 1. On the right side, it's 83, and on the left side, it's 78. I just imagine without a spouse around, that there's a lot of people just not getting, it's increasing, not, you know, a higher number of people not getting the care they need, particularly if they don't have a lot of funds. If they have a lot of funds, at 5% gets paid care, there's probably like at least 5 or 10% that really need a lot of care and they're just not getting anything.
Yeah. Yeah. Now, these are people, I think we limited it to people in the community. And so, it might be interesting then to look at sort of the transition rates to nursing homes and other sort of higher levels of care to fill that gap. But I think you make a good point.
Anyway, I'll stop there. It's just very interesting. Go ahead.
Yeah. So a lot of people have looked at the cost of dementia. I guess we're hoping we can fill in these estimates. The last best estimates came, probably the most cited, I should say. I don't know if they're the best, but the most cited estimates come from that New England Journal paper by Hurd and colleagues from RAND. And I guess that's a little over 10 years old now, which we're hoping to update. And they reported, the annual cost of dementia to be about $56,000. $15,000 of that was an extra cost to Medicare. Most of that additional cost is incurred by families, either through the value of their caregiving or out-of-pocket spending for medical care or nursing home care or assisted living, for example. So in summary, people living with dementia require a significant amount of long-term care services and supports. Family caregivers are really the largest providers of care. In response to the need to better support people with dementia, the National Alzheimer's Project Act, I think was started during the Obama administration and has been kind of going on since then. They highlight a number of important objectives and goals for researchers, people in policy, and people in practice. And I highlight two of these sort of statement or goals that they put forward, because this is what our work is directly addressing. So one is we need to study comprehensive dementia care from the time of diagnosis to end of life and associated costs. And hopefully you'll get to see how our modeling framework can inform that sort of statement or goal. And then the second is we need to provide a framework for policymakers to begin to estimate costs and benefits of policies and programs aimed to help caregivers. And again, hopefully, by the end of this, you'll have an understanding of how our modeling framework would enable policymakers, decision makers at various levels to understand the costs and benefits of different programs that support caregivers. So our study objective is to determine the cost effectiveness of non-drug interventions that support people with dementia and their family, friend, care partners. We'll be looking at the cost effectiveness of these interventions using our individual microsimulation model. We first published findings from the model in JAGS in, I guess it was 2017 now, where we used the model to report on the lifetime cost of dementia. And we disaggregated the lifetime cost in terms of who is responsible for that care. Again, finding consistent with all the other studies out there that families really bear the financial burden of the disease. We have a grant right now that's nearing the end, an R01 that was looking at the cost effectiveness of non-drug interventions that support people with dementia. And we've used our modeling framework to do that. We published a paper, I guess it was last year, maybe middle of last year, on the cost effectiveness of non-drug interventions that reduce nursing home admissions for people with dementia. So we'll share some of those results. And now we're working on writing up and submitting a paper on non-drug interventions that reduce functional decline and or manage behavioral symptoms for people with dementia. So we'll talk about the model structure. We'll go into detail about the measures in the model, the data, the model parameters, and then how we're modifying this simulation model to look at the cost effectiveness of the different treatments. So this is a figure or schematic of the structure of the model. It's an individual microsimulation. Basically what that means is we create or simulate an individual that represents an incident person with dementia. This simulated incident person with dementia has a number of characteristics that we hope and aim to make it representative of an average person diagnosed with dementia. So this simulated incident person with dementia has an age of onset, for example, an educational attainment, so number of years of education, a net worth or income, a gender, a race, comorbidities, characteristics of their family caregiver. So all these sort of background characteristics that you would include sort of in a table one if you were describing a population of people with dementia, people newly diagnosed with dementia, we aim for this person to be representative of sort of what the average person in the US looks like. And we do this by we used HRS data to inform these characteristics. This individual, simulated individual, then interacts with the model where we generate 3 major sets of predictions. The first set of predictions are around the individual's cognition, function, and behavior. And so at any given month from diagnosis to death, we predict their cognition, function, and behavior. We then use their personal characteristics, their clinical features to predict their risk and whether or not these risks are realized of transitioning from the community to nursing home, becoming enrolled in Medicaid, so a dual, and their risk of and whether or not they die in the month. And then we use these pieces of information to predict their costs associated with their disease, place of residence, and Medicaid status in a month. And so an individual cycles through the model in monthly increments. At the beginning of the month, we sort of predict their cognition, function, and behavior, their transitions, their costs, and they cycle through in monthly increments. All the while, in the background, we're keeping track of their cumulative costs, their time in the community, time in nursing home, and they continue to cycle until they're predicted to die. And then for one individual, that represents their sort of lifetime experience with dementia. What we do is we repeat this process for a very large number of simulated individuals, and then can get a sense of, for example, the average lifetime cost of dementia, or the average time a person with dementia spends in the community. And then what you're going to see when we get to it, we modified this modeling approach to conduct essentially, I've been calling it a simulated counterfactual experiment, where we'll generate 2 versions, 2 copies of the same simulated person. One will be exposed to dementia usual care, which is kind of what I just described. And then their counterfactual version will be assigned to a treatment effect that is based on the literature. Because they have a treatment effect, for example, a lower risk of transitioning to a nursing home, or a slower rate of functional decline or fewer behavioral symptoms, they'll have different costs and different transitions and different experiences, and then we'll compare the 2 to understand the effects of an intervention. Before we get into that, I just want to go into some more detail about the structure of the model, get a little more concrete. Cognition, function, and behavior are the key sort of clinical features or symptoms of the disease we're modeling. We're using measures that are available in the data sets we're drawing on. So cognition is going to be modeled based on the MMSE. Lower scores indicate more cognitive impairment. MMSE, I think fairly well known, at least in the research world, has a number of known limitations. But the main strength of MMSE and all these measures, again, is that they're sort of common across the different data sets we're drawing on to build out the model. Function, we're going to use a modified version of the functional activities questionnaire. Basically, there's 10 ADL, IADL sort of domains, and we sort of predict or determine whether or not a person has a limitation in each one of these ADLs, IADLs. It goes from 0 to 10 limitations. And then behavior is based on the MPIQ, which I think it's either 10 or 12 different behavioral symptoms, whether or not they're present. So agitation, aggression, wandering, among other things. And so higher scores indicate a person has more behavioral symptoms. So we're drawing on a number of different data sources to build out the model. Ideally, there would have been a single data set that existed that kind of had all the information we need, and we wouldn't have to sort of do all this work of building out a simulation model. But that's not the case. Instead, what happens is there's sort of these different data sets that, when put together in the structure of a simulation model, allow us to sort of ask and try to answer some of these questions around what is the lifetime cost associated with dementia, what's the cost effectiveness of implementing this intervention versus not. So you'll recall our first set of predictions are around the clinical features of dementia, cognition, function, behavior. We're going to draw on data from the National Alzheimer's Coordinating Center Uniform Dataset, I think more commonly known as NAC. What's really powerful about NAC is it provides a clinical diagnosis of dementia. and it's longitudinal. And so you can see when somebody is diagnosed with dementia, you can follow them over time. And over time, you can see how these clinical features change. The main limitation with NAC is that it is obtained from Alzheimer's disease centers. And so people who go to Alzheimer's disease centers, I think Johns Hopkins has one, are probably not representative of the average person with dementia. So there's a sort of generalizability or potential generalizability issue. The second set of predictions are about moving in terms of place of residence, going from the community to nursing home, transitioning to full Medicaid and mortality. We're going to use a couple of different data sets for this. For transitions in place of residence, we draw initially on the NAC data. I worked with he was actually a master's student, Peter Shoemaker, who for his thesis calibrated our model so that the predicted time people spend in the nursing home in the simulation model match or get closer to matching what's observed in Medicare data. And so he actually published a paper in Medical Decision Making on his calibration approach and comparing the results. So we, when I first did this model, we used the NAC data. He did a great job updating the model to calibrate against Medicare data. We're going to use Medicare enrollment data to determine transitions to Medicaid. And then mortality is going to come from the literature. The last set of predictions are around costs. What we want to do is say, what's the cost associated with this level of clinical features? We're going to draw on data from ADAMS, which is a subsample of the health and retirement study. The two data sets can actually be linked together, and we link that also with CMS Medicare data. What's powerful about ADAMS is it provides a clinical diagnosis of dementia. It has information on the key clinical features, cognition, function, and behavior. It has information on key costs, including out-of-pocket spending, time caregiving, and then when merged in with the CMS data, the Medicare expenditures. The main limitation of ADAMS is that it is cross-sectional. And I guess at this point, now a little bit older, although when we first started working on this project, it was sort of not as far away as when the sample was collected. So our clinical trajectories, what we want to do is describe how cognition, function, and behavior change over time from diagnosis to death. We used linear mixed effects models, our NAC data. We included terms for time squared. We had random intercepts, random slopes, and we included a number of sociodemographic and clinical risk factors that could also be associated with decline. We published those results just on the clinical trajectories in the Journals of Gerontology Series A in about 2017, I think it came out. And basically, what we get from those linear mixed effects models are ways of predicting trajectories. These are sort of an average trajectory for, I don't remember the exact demographic characteristics of the person, but you can imagine how different demographic characteristics, including age of onset, gender, race, income, comorbidities, have implications in terms of not only the intercept, or when somebody, their level of the clinical features when they're diagnosed, but also the slope, how quickly they're declining in terms of these symptoms. Next set of predictions, again, around transitions. The first transition of relevance is moving from the community to a nursing home. Initially, we used the NAC data and we built a Weibull survival model. What's really nice about this is by using the NAC data, we were able to directly connect and include terms for cognition, function, and behavior. And so we can say with this model, what is the risk of transitioning to a nursing home based on your clinical features in this given month, which was really powerful and allowed us to sort of understand how underlying disease process or how clinical symptoms features impact risks of transitions. Then my graduate student came along. He was like, we can maybe make some of these predictions a little better. He calibrated our Weibull survival model so that the predicted time people spend in the nursing home in our model get closer to what's observed in the Medicare data. So before the calibration, the difference in months between the predicted time in the nursing home, what the model was saying people were spending in the nursing home, versus what was observed in Medicare data, we were off by about 3.74 months. Sometimes we over-predicted, sometimes we under-predicted. After his calibration, we were off, or now we're off by about 1.47 months. So much better and getting a lot closer to what's observed in data. Other transitions. So we modeled the probability of transitioning from the nursing home back to the community. There's actually a few of these that occur. We're drawing on some estimates from an Arling study that happened some time ago, where he looked at some of these, we call them reverse transitions. Medicaid transitions come from the MBSF and the residential history file, which we have here at Brown. Residential history file, for those of you who may not know, is pretty cool. What we have is a way of identifying in the Medicare data. We have a structured file that draws on the Medicare data to say at any given point in time where somebody is residing in the home, in the community, in the home, in the nursing home. And if they're in the nursing home, are they a long stay resident, or is it for skilled nursing care? We also are able to identify if they're at any given point in time in the hospital or had an emergency department visit. So it takes all the information across the Medicare files and just organizes it in a way where we can see more easily place of residence for people. So we use that to help inform the Medicaid transitions. And then mortality, we used life table data and then also some estimates from the literature, which basically give different estimated survival times based on age of onset, gender, and race of the person with dementia. Cost inputs, what we want to do is describe the relationship between the clinical features, so cognition, function, and behavior, and various types of costs. We're predominantly interested in out-of-pocket spending for medical care, but also out-of-pocket spending for nursing home care. We look at the time spent receiving informal or family care, the amount of formal community-based care people receive, and Medicare expenditures. Again, we're using our ADAMS, HRS, CMS Medicare data. We used the two-part modeling approach and included our terms for cognition, function, and behavior, again, to understand the association between those clinical features and the various types of costs. Each of these cost categories were estimated as separate outcomes. So we had 4 different models here. I think probably some of the folks in the room here have had challenges with this, but what we wanted to do was figure out what is the value of the family caregiving or informal care. We used an opportunity cost approach, and basically there's a number of different estimates in the literature. We drew on a study in health services research that talked about the opportunity cost of caregiving. Basically, they, long story short, they had some data and they found that I think the opportunity cost varied by age of the caregiver as well as the gender. And based on the composition of caregivers of people with dementia, we sort of back into an estimate of about $19.71 an hour as the opportunity cost of family caregiving. Formal community care based care was priced based on a study we found that looked at sort of the average cost of hiring somebody to come in and provide some sort of caregiving. And then the estimates for nursing home care, which these might need to be updated. These estimates come from, I think, 2017. So I'm pretty sure these values have gone up since then. But you can see those here. So we spent a lot of our effort, in part because of where the data was, on modeling the clinical features and costs and transitions. One area that I think we struggle with still and have been thinking a lot about, though I'm not sure I have a solution yet, so maybe folks in this room have a better answer, is understanding the preference weights for different levels of dementia. And the preference weights are important if we're looking at the cost effectiveness of non-drug interventions, because preference weights are used to calculate quality adjusted life years. So if we're looking at the cost effectiveness of these interventions, one component of cost effectiveness is cost. The other is effectiveness, and effectiveness can be measured a number of different ways, but sort of the preferred way is in quality adjusted life years. To do that, you need these preference weights. And so we spent a lot of time searching the literature for ways to estimate preference weights for people with dementia. And we ultimately settled on these weights that were obtained from Peter Newman and colleagues from, I think, some time ago now, where he did a study looking at preference weights for people with dementia. I understand he's working on updating these, but that's work in progress. And so his preference weights were sort of stratified by stage of dementia, mild, moderate, severe, as well as place of residence, community, and nursing home. And so we implemented these preference weights in our model. And you'll see in a bit when I share some of the cost effectiveness results, why I think these might not be the best estimates for how we're modeling the disease. So our model, I think, structure isn't sensitive enough to capture this parameterization of quality of life and preference weights.
Eric, can you look at that by age? Like I noticed that the nursing home preference weights are actually higher for mild than community. Like what's going on there?
You know, this comes from like a table 3 in his paper. And so I think it's just, he didn't break it out by age. And we've noticed that in the past, and we're not, 100% sure why that's the case. He also, these preference rates were originally reported by, what's it called? The CDR, Clinical Dementia Rating Scale, I think, which we converted. We used the sort of conversion to map these onto the MMSE, which fits how we're modeling the disease. So that's another important difference. There are other preference weight functions or ways of obtaining preference weights reported in the literature for people with dementia. The challenge is we can't map those approaches onto how other aspects of the model are parameterized. So this was like the only way we could think of that would fit in our sort of structure of the model. So it's kind of a limitation. But it would be cool if he did provide it by age or other features as well. Maybe in some of his new work when it comes out, he'll do that. Thanks. So just to kind of summarize what we have now is for a person from diagnosis to death, we have a way of mapping their clinical trajectories in terms of their cognition, function, and behavior. We have a way of looking.
Eric, just to interrupt, there's a note from Karen or Jennifer in the chat about can you help interpret the weights for community nursing home for the mild case?
Yeah, let's try to go back. Yeah, I don't know. We don't know why they're off. They're switched around from how you would have expected. I don't think they're off by a lot. And so if there's anybody who does a lot of work in preference weights on the line, they might be able to comment on the magnitude of difference. But I don't think it's, a point, was that 03, is not like that big of a difference. But yeah, it is odd, and I don't have a good answer for why they would be sort of flipped around than what we would have expected.
But I guess I don't understand. I don't live in this world, and it looks to me that like most people with mild impairment prefer the community, but then the percentage reporting nursing home, like the 71.
Okay,
like,
yeah.
I just don't understand what's in the table.
So these are weights. Essentially, think of it as like one is like perfect health, or you would this is completely preferred, and 0 is like completely unpreferred. Like you wouldn't want it. That's like being dead. So a higher number is better. And basically the way you calculate a quality adjusted life year is you would multiply the amount of months a person spends with a given preference weight by those months. And so if a person spent all 12 months in in the community in mild dementia, you would multiply their months by the preference weight, and that would give you their quality adjusted life year. And what we're going to do is multiply their different places of residence and their stages of dementia to calculate their total quality adjusted life years, with 1 as a reference as like perfect, complete health, and 0 as a reference as like essentially dead or completely undesirable. And the way these weights are obtained, there's a couple of different ways to do it, but one way that people do it is they ask sort of these, what they're called standard gamble type questions, where they ask people to make trade-offs between different sort of scenarios that describe health. And there's sort of risk involved, and there's a whole methodology behind it. And basically what they're trying to do is get at sort of how much do people prefer different levels of health. And then that's used to sort of weight their overall quality of life. So I'm not sure if that like does any justice to your question or helps you.
That's helpful. It's just it's I think surprising to me that it looks like it's, you know, the setting is that folks are sort of agnostic about setting with mild impairment and willing to be in a nursing home. That surprises me.
It surprises, I think, it surprises me also. We're not 100% sure kind of what's going on. And again, we took this data from a published paper, and so we're kind of limited to what we can infer from that paper. And the reason we took it from that paper is because this structure for the weights is easier to parameterize in our modeling structure than some of the other estimates that are out there. So we're kind of like trying to fill in pieces of a puzzle and just drawing what works with how we're structuring things, which, you know, our structure might not be the best also. Okay, yeah, so to recap, what we have is a way of identifying where people lie on their clinical features from diagnosis to death. We have a way of linking their clinical features with their risk of transitioning to long-term care facility or nursing home, their risk of transitioning to Medicaid, and the costs they're incurring. What we're going to do is use this modeling structure to conduct, again, sort of these simulated counterfactual experiments. We're going to generate 2 versions of the same sort of simulated person with dementia. One will be assigned to dementia usual care. The other version will be assigned to the intervention. The dementia usual care sort of goes through the experience I just talked about. The person that's assigned to the intervention will have different transitions and different costs because they are experiencing an intervention effect, like a lower risk of transitioning to a nursing home. So the question becomes, how do we identify or what interventions do we model? This is a figure that actually comes from the NIA Impact Collaboratory Dissemination and Implementation Core, where they mapped out the different intervention settings that studies were published in, as well as the target outcomes. And so we used their sort of scan of the literature to identify interventions that targeted behaviors, ADLs, IADLs, as well as nursing home placement. And we did that because these are sort of parameters or things that we can sort of modify and model in our modeling structure. We ultimately settled, based on reviewing the studies that they identified, on we identified 8 interventions that we could model that could be parameterized in our framework. 4 of these interventions, the bottom 4 reduced the risk of transitioning to a nursing home, and that was the Alzheimer's and dementia paper that I had a figure for. And then 4 we're working on summarizing the results right now, either addressed or reduced the number of behavioral symptoms or reduced the rate of functional decline. Some of these interventions also reported reductions on other outcomes that we were able to model as well. So COPE and Alzheimer's and dementia care reported reductions in Medicare costs, so we were able to directly model that. And then mind and tap, two other interventions, reported reductions in time spent caregiving, and we were able to model that as well. A couple of other key points for this slide is, one, these interventions are implemented in different settings of care. So some of these are implemented in primary care, some in the home, one in adult day. The duration of the treatment effect varied greatly, but in part, this is a reflection of the follow-up time of the different studies. So some studies had 42-month follow-up, others only had a 4-month follow-up. And so to be conservative in our modeling, we took whatever the sort of last reported follow-up was from the source study and modeled up to that point and didn't extend beyond that. In sensitivity analyses, we did, but in our sort of primary approach, we just said if the study reported results out to 3 months, that's the duration we assumed the treatment effect would last.
Gail, I see your hand up. Do you want to chime in?
Sure. I was going to wait until the end of the presentation. I didn't want to interrupt you. Should I wait?
You can go ahead.
Okay. By the way, great presentation. You might have mentioned this already, but I wanted to focus in on the non-pharmacological inventory, the NPIQ. And my question is, are any of the study's non-pharmacological predictions of interventions you propose, specifically, I'm thinking of depression, are any of these more amenable in terms of showing greater, I guess, outcomes for reducing costs? So I guess my point is that does depression play a viable, role in improving the clinical diagnosis of those who are cognitively impaired? So you can reduce costs specifically by, focusing interventions on people that have more depression-related, dementia. Because some of the, like you said, it's modifiable, but some of the dementia, especially in Black and brown older adults, it's mixed with stress and depression. And I'm wondering if interventions, non-pharmacological interventions that focus on that may be able to restore some components of everyday function so that you can reduce costs associated with them having, a care provider be with them all the time. I'm just interested because I haven't seen any studies that specifically focus on those types of, clinical interventions with depression per se.
Mm-hmm. Mm-hmm. Yeah. Okay. I'll try to answer it based on what I think the question is. So we look at the summary, like measure of behavior, MPIQ, the effect on that. Depression and anxiety, I think, are individual like domains or items within the MPIQ and contribute to it. And so in that sense, we would be sort of accounting and modeling it. Some of the individual source papers or trials looking at these interventions, I'm thinking of TAP, for example. They've looked at specific behaviors or symptoms within the MPIQ, like at the item or domain level, and have reported findings. So I think TAP, for example, reported findings of reductions in depressive symptoms, and I don't recall the exact findings. I can send you the paper, but they reported differential effects based on the person with dementia and caregiver's race, kind of getting to what you were saying. African-American, Black families, people with dementia had a different response in terms of the domains of the MPI versus white caregivers. They all, I think, had benefits, but sort of the items that they were improving on differed. So I can send you that paper if it's helpful. What we do is we don't look at the individual sort of domains or items. We look at the total summary score. But certainly, I think the concept and the sort of theory frameworks behind these interventions, at least some of them, are getting at what you're talking about. They're addressing, they're personalized interventions that are addressing could be addressing stress of the caregiver, aspects related to home environment, aspects related to improving function and
Thank
behavior.
you. Thank you, Eric. Excellent response. I'll follow up with you. Thank you so much.
Yeah. Happy to forward the papers along. The other point
And,
I want.
Eric, we got about 10 more minutes. Just
Okay, sounds good. I'll. We're almost at the end anyway. The other point I want to make about this slide, and something that we've received feedback from reviewers about, is our approach has always been to compare each intervention to usual care instead of the interventions relative to each other. And reviewers have pushed back or have said and asked us, why don't we compare them to each other? And our sort of view has been that these interventions are actually complementary. They're not competing with each other. The interventions target people at different stages of the disease. So some of these focus more on the earlier stage, while others are enrolling and targeting people in the middle or later stage of the disease. The interventions target people in different settings of care. And so our approach has always been to compare each intervention versus its own usual care instead of comparing them all to each other. So I'll just comment on this and then we'll go to the results. One of the challenging aspects of our modeling approach has always been that we model people from the time they're diagnosed till they die. The interventions enroll people at different stages of dementia. They're not enrolling people when they're diagnosed and then sort of applying the intervention at a given point in time. They're sort of drawing from the sample or from the population of people with dementia who meet their inclusion criteria. So there's always been a challenge of trying to match up in our modeling framework. When should we apply the treatment effects from the study? And so we spent a lot of time thinking about this. Our solution was that we would model an incident cohort of people with dementia. And what we do is we try to find the point that that incident cohort reaches the same stage that the source randomized trial describes as the baseline characteristics that they enroll. And so that means we try to match either the time since dementia onset, if it's reported in the source trial, or the baseline clinical features as reported in the source trial. Most source trials have reported, for example, MMSE score. And so we'll model an incident population until they reach the same MMSE score as reported in one of the interventions we're modeling. And we'll say, among that group of people in our simulation that are still alive, then you're eligible to receive the intervention effect. Interest of time, I'll just kind of skip to the results. These are the interventions that that targeted either function and behavior. We broke out costs by sort of who's responsible for that. And then we also calculated the total net societal cost. So each row is comparing the intervention relative to its own usual care. And so collaborative care, for example, resulted in a total net savings of $572, even after accounting for the intervention cost. COPE had the largest cost savings of around $5,200. And that's in part because COPE also provided data on the Medicare cost savings, which we were able to incorporate, and that contributed to a large benefit. Skills to Care was the only intervention that resulted in a net increase in cost. It was a small net increase, but a net increase nonetheless. You see the issue here with the qualities in that our model is really not being able to pick up differences in the health-related quality of life between the treatment and usual care based on how we're parameterizing quality of life, which is based primarily on disease severity as modeled by the MMSE or by place of residence. These interventions, their primary target is on the function and behavior, which indirectly will affect transitions to nursing home. But because of the duration of the studies, we're not seeing large reductions in the number of people that would have transitioned to a nursing home, and that's affecting our quality estimates.
Eric, you're showing all the cost savings for the cost of the intervention itself. Who is the payer? Like, is it Medicare and Medicaid? Is it health systems? Like who's actually, bearing these costs?
Well, I think it depends. The Medicare, Medicaid. Are you asking about like the different columns? So
Well, so that's like savings eventually to Medicare, but like how much did, TAP cost?
TAP cost like $1,100, but this is the I see what you're saying. I think we only report here the net societal cost savings. These are not net for Medicare and Medicaid. The average cost for these interventions roughly around $800 to $1,500 per person per like duration of the intervention, roughly between like 4 to 12 months.
But that $800 or $1,500, like who's on the hook for that? It's a health system, or it's.
Well, that historically has been the issue, that Medicare fee-for-service has not paid for these. This is something where Medicare Advantage would potentially be able to pay for, either through their care management benefits or their new supplemental benefits. And this is also why the VA represents a really good potential system of care, because they can, they're more holistic in their approach, and they care about a broader set of outcomes. Recently, Medicare Advantage, or not Medicare Advantage, Medicare fee-for-service has started implementing CPT codes that could potentially pay for some of these interventions or key aspects of the intervention. So Medicare now has, I think just this year, they introduced codes for caregiver training, and they have codes for cognitive care planning, and of course, like the guide model. And so these are all sort of big payment reforms that are happening that now make it potentially feasible for providers, health systems to implement these interventions, get paid for them from Medicare, fee-for-service, Medicare Advantage. But thank you for that question. That's a good point. Yeah.
So we just have a couple.
you-
Go ahead, Karen.
Oh, my question was, did you say that the COPE study was the only one to incorporate Medicare costs? And so should we be kind of learning from this that there's high potential for savings in the Medicare program?
Yeah.
And is that coming through hospitalizations or?
COPE benefits were achieved through reductions in emergency department visits, and that was the big one, and then reductions in hospitalizations. Yeah.
And other interventions just didn't even measure that. Is that correct?
Right.
Okay.
Right. So some in the next Alzheimer's dementia care was the only other study that actually measured and evaluated Medicare expenditures. And part of it is because of the design of the studies. COPE and Alzheimer's dementia care, they were more pragmatic in nature. And so they were done either at like a health system level, or the COPE study was done as a within a Medicaid, an HCBS waiver. The other studies were less pragmatic in nature, and so had, we didn't have those data, or they didn't have those data available to them.
So we're really getting down to the wire here. Eric, do you have any final thoughts to wrap things up? I know there's questions, but people are going to have to split right at once.
Oh yeah. So our work is continuing to look at cost effectiveness of these non-drug interventions. The evolving payment models now, I think, make it more compelling and a stronger business case for health systems to be able to implement these. And so our work is also shifting towards helping disseminate and implement these programs. But yeah, those are the main things. Thank you for your time. I appreciate the opportunity to share, and thank you for all the great questions.
Thank you, Eric. There's a lot of appreciation in the chat there, and there might be a couple questions people have. Is it okay if they ping you with those questions by email?
Definitely, yeah.
Thank you so much, Eric, and thank you to all of our heads participants. It was really great time together. So thanks, Eric, and see everybody.
All right, see you. Thanks, Dan. Thanks, Jennifer.